Good evening, ladies and gentlemen. Welcome you all to this webinar on ECG, Basic and Beyond. This is our 9th lecture. Today's topic is supraventricular tachycardia. Our today's speaker is our teacher, our international advisor, Dr. Rafiq Ahmed sir. And we have got two of our course directors with us, Professor M. Athar Ali and Professor Abdul Wadud Chaudhuri. And we have got our number of teachers and colleagues, respected persons in our panelist, including Professor Jakir Sir, Professor Mohsin Hossain, Professor Arun Maske, Professor M.G. Azam, Professor Sajal Banerjee Sir, and many other teachers. May I request Professor M. Athar Ali Sir to say a few words about today's topic in brief.
একটু ভুল হলো, আসলে আজকে লেকচার কিন্তু আতার ভাই দিবেন।
Oh, sorry. Today our speaker is Professor M. Athar Ali sir. We have got our international advisor, Dr. Rafiq Ahmed sir, with us. May I request Professor Abdul Wadud Chaudhuri sir to say a few words about today's topic. First, a brief comment, and then Professor M. Athar Ali will start his presentation.
I think a lot of people are actually waiting for Athar Bhai's lecture. His lecture is always very informative, very entertaining, very funny, very enjoyable. And always you can take something to your home, new thing. Even us who claim to know a little bit, we also always come to know a little bit more from his lectures. And supraventricular tachycardia, very favorite in the exam and also very important in the daily practice. I think without much ado, Professor Athar Ali can start our today's lecture. Athar Bhai, you are welcome.
Thank you, sir. Our today's speaker is Professor M. Athar Ali sir. I think every one of you know him about him. He's our teacher. He's one of the pioneer in the electrophysiology of Bangladesh. And may I request Professor M. Athar Ali sir to start his lecture, to deliver his lecture. Professor M. Athar Ali sir, please.
Thank you, Dr. Firoz, for your nice introduction, and Professor Abdul Wadud Chaudhuri. And I also thank you very much for your excellent introduction. And it is very much not very easy to talk on ECG in front of the such distinguished faculties, particularly our teacher, Rupik sir, Sajal Banerjee sir, Abdullah Jamil, and Professor Abdul Wadud Chaudhuri, and so many Professor Zakir Hussain also. And as you know, there are 3 segments of our session. Just after what is Dr. Firoz already told, that is not wrong actually. After my lecture, there will be the most interesting session that will be done by the Professor Dr. Rupik Ahmed sir. So yes. There will be a second section that is the most interesting session, that is interactive ECG session, just after my talk. My talk will be very short, particularly on the supraventricular tachycardia. So I want to share my screen.
আসি নাই এখনো।
Can you see the screen?
No, sir, not yet.
তবে স্ক্রিনের নিচে গ্রিন যে আপ অ্যারো আছে ওটাতে ক্লিক করলে শো হবে।
হ্যাঁ, দাঁড়াও। হ্যাঁ,
নিচের প্যানেলে গ্রিন আপ অ্যারো আছে একটা।
নেই কিন্তু।
Share screen এক সবুজ বাটন স্যার।
স্যার আপনি কি শেয়ার স্ক্রিনটা খুঁজে পেয়েছেন স্যার?
শেয়ার স্ক্রিন পাইছি কিন্তু আমার
আচ্ছা, শেয়ার স্ক্রিনে প্রথমে ডাবল ক্লিক করেন স্যার, দুইটা ক্লিক করেন।
আচ্ছা, এখনো তো স্লাইড দেখা যাচ্ছে না, না?
এখন হচ্ছে আপনার স্ক্রিনটা আসবে।
না
ওই
স্যার, দেখা যাচ্ছে না এখন আছে।
হ্যাঁ, আপনার স্ক্রিনে যেই ফাইলটা করতে যাচ্ছেন ওটাকে ডাবল ক্লিক করেন।
জাস্ট এ মিনিট, হ্যাঁ আপু দেখো তো শেয়ার স্ক্রিনটা। না তো এই যে কি আসছে এটা?
আর গেছে
দেখা যায় আর
না এখন আর কিছু
আচ্ছা যাই, হ্যাঁ
স্যার এখনো আসেনি স্যার।
না দাঁড়া একটু, হ্যাঁ হ্যাঁ
এখন আসছে স্যার।
আচ্ছা দাঁড়া
এখন
একটু।
আসছে।
এখন আপনি ফার্স্ট লেকচার
ইয়েস স্যার, ইটস কামিং।
ঠিক আছে, স্লাইড শুরুতে যান। প্রথম লেকচারে প্রথম স্লাইডে যান স্যার, ব্যাক করে।
এইটা এই পাশে নিয়ে আসো তো, হ্যাঁ
ঠিক আছে স্যার, শুরু করেন স্যার এবার।
ডান পাশে, হ্যাঁ রাইট, হ্যাঁ
স্ক্রিন বড়
আমারটা দেখা তো, হ্যাঁ গুড।
স্ক্রিন বড় করে দিয়েছেন স্যার?
আচ্ছা এখন দেখা যায় ফিরোজ?
জি স্যার, দেখা যাচ্ছে স্যার, দেখা যাচ্ছে। এখন শুরু করতে পারেন স্যার।
Sorry for the interruption. So it is supraventricular tachycardia on which I will talk. দেখা যায় ফিরোজ?
জি স্যার, দেখা যাচ্ছে স্যার, শোনা যাচ্ছে, দেখা যাচ্ছে।
So supraventricular tachycardia is a group of arrhythmias, the substrate of which is either in the atrium or in the AV node, like this, either in the atrium or AV node where the substrate are situated. And on this basis, the supraventricular tachycardia can be classified into either atrial tachycardia or the nodal tachycardias. The atrial tachycardias already discussed by our Dr. Rafiq Ahmed sir in the previous lecture. I will concentrate just talk on the nodal tachycardias, that is AVNRT, AVRT and junctional tachycardias. Today's lecture particularly on this. And supraventricular tachycardia again can be subdivided into another group that is called the paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia is the special characteristics of the clinical characteristics of these groups of the tachycardia. We start suddenly, stop spontaneously, and usually the mechanism is re-entry. So I will talk supraventricular tachycardia, particularly paroxysmal supraventricular tachycardia, which includes AVNRT, AVRT, and junctional tachycardia, as because the atrial tachycardia is already discussed by Dr. Rafiq Ahmed sir. So this is the group of the supraventricular tachycardia, and ECG is the main. ECG is the main key for classifying these groups of the tachycardia. First of all, these groups of the tachycardia can be divided into narrow QRS tachycardia and the wide QRS tachycardia by the ECG. And secondly, the narrow QRS tachycardia can be again divided into irregular tachycardias and regular tachycardias. And these are the examples of all the supraventricular tachycardias, that is atrial fibrillation, atrial flutter, atrial tachycardia, AV nodal re-entry tachycardia, and atrioventricular nodal tachycardia. These are the examples of the narrow QRS regular and irregular supraventricular tachycardia. And again, the wide QRS tachycardias may be again classified into aberration or with the pre-excitation. So these are the groups of the supraventricular tachycardias, and that can be classified on the basis of their ECG. And although there are several numbers of the examples of the supraventricular tachycardias, but we can summarize by ECG all the supraventricular tachycardias into 4 groups. That is, this is one of the ECG, that is, this is the regular narrow complex tachycardia. This is one of the presentation of the supraventricular tachycardia, that is regular narrow complex tachycardia. This is another group, that is the regular, that is irregular narrow complex tachycardia. This is also one of the examples of the presentation of the supraventricular tachycardia. This is another group, that is wide QRS complex tachycardia, that is the regular wide complex tachycardia, and this is another group, that is the irregular wide complex tachycardia. So these are the four groups of ECG that represent actually the whole groups of the supraventricular tachycardia. So these are the four ECG. Actually, if we analyze this, if we can analyze these four ECG, we can, I think, diagnose most of the supraventricular tachycardia. So these are the four groups of the supraventricular tachycardias: regular narrow complex, irregular narrow complex, regular wide complex, and irregular wide complex. And P, that is the P wave, as we know, there is a systemic approach for the analysis of the arrhythmias, and particularly in this case, particularly for the analysis of the supraventricular tachycardias, this is the P wave that plays the key role for analyzing these groups of the supraventricular tachycardias, P. And particularly the characters of the P, that is the morphology of the P wave, axis of the P wave, RPR and the RP relationship of the P wave, and relation of the P wave, the QRS complex. These are the four important criteria of the P wave. So we have to find out to see the P waves in the supraventricular tachycardias, whether it is seen or not seen. And then we have to analyze the morphology axis, PR and RP, and the relation of the QRS complex. So these are the key ways to diagnose the supraventricular tachycardias. And not only the P, all these criteria, P rate has got also some important roles for classifying the supraventricular tachycardias. As for example, sinus tachycardia, usually the rate is more than 100 beats per minute, and this is the this is the sinus tachycardia. The rate is usually more than 100 beats per minute. This is the atrial tachycardia. The rate is usually 150 plus minus 50 beats per minute. This is the supraventricular tachycardia. The rate is usually 200 plus minus 50 beats per minute. And this is the atrial flutter, and this is the atrial fibrillation. So there is some unknown reason. There are some rate relationship of this types of the tachycardia with the, so P rate, that is the rate of the atrial depolarization, or the P rate, or we can see sometimes it is the flutter rate or the fibrillation rate. So it is the atrial depolarization rate that helps to diagnose the supraventricular tachycardia. So rate has got also some important role. As for example, this is one of the examples of the narrow complex regular tachycardia. This is the narrow complex regular tachycardia. Here the heart rate is 150 beats per minute. You see the rate is in the rate is about, that is P rate is about 300. Here see, this is the P, and the rate is nearly 300 beats per minute. That is the atrial depolarization rate or the P rate. And also in this case, also the P rate is nearly 300. So from the rate, what we can suspect, this can be a case of the atrial flutter, as because we know the rate of the atrial flutter is P rate is nearly about 300 beats per minute plus 50. So this is the, by analyzing the P rate, we can tell that this may be a case of the supraventricular, that is the atrial supraventricular tachycardia, particularly the atrial flutter. And if we further analysis, then we can see there is the sawtooth appearance of the, there is no clean cut P waves. This is the no isoelectric line. So these are the suggestion of the atrial flutter. So this is the atrial flutter. This is the example of the atrial flutter. But sometimes the P waves are not similar. As for example, in this case, this is the P wave, this is the P wave. The P waves are very clean cut, and something not that is not usual like the atrial flutter. So big size the P waves. So but the rate is nearly 300. The rate is 300. That rate suggests the atrial flutter, and the P wave morphology is like this. And here you can see this is the positive P waves, and here you can see the negative P waves. And the rate is fixed. That is atrial. That is the 150 rate. That is fixed 150. So that is atrial rate 300, ventricular rate 150. That is 2:1 conduction, no isoelectric line, and the sawtooth of the flutter appearance all suggest this can be a case of the atrial flutter. So there is the P wave morphology. P wave rate has got some important role for classifying these groups of the narrow complex regular tachycardia, what type of it is. I will not discuss it further as it is shown by the Dr. Rahiduzzaman sir in the previous lecture, but just as it has got some relation with the supraventricular tachycardia. So this is the example how we can classify, that is how we can analyze that is supraventricular tachycardia. So here the P is unusual is because this patient has got the structural heart disease. This is the case of the tetralogy of the flat. So this is the reason the P looks like this, but not in the previous ECG. So, but the location of the P has got tremendous role. This slide was shown by Dr. O.P. sir in previous lecture. I will again show this as because this conception is very important for analyzing the supraventricular tachycardia, as because the relation of the P with the QRS complex, the location of the P in the ECG is very much important. As for example, in the first row, there is no P wave, visible P wave. This is the QRS complex, the P is within the QRS complex. That is, this may be a case of the supraventricular tachycardia where we cannot see the P wave. And sometimes we can see the P wave just after the QRS. And but the P wave is just close to the QRS complex. The interval from the R to P is less than 80 milliseconds. That is less than the two small squares. So this may be one of the location of the P wave, that is the RP relation, that is the interval may be less than 80 milliseconds. And again, the P wave location may be further away from the previous QRS complex, that is the inverted P, and the RP, that is the R and this is the P. This interval may be more than 80 milliseconds, that is more than two small squares. So this, and this is again another is another kind of the supraventricular tachycardia where the location of the P wave may be just before the next QRS complex, but the P is positive. So this kind of these are the long RP tachycardia. That is the R and this is the P, and this is the P and this is the R. So RP is longer than the PR. So this is the long RP tachycardia, but the P is positive here. And this is another group. This is the R and this is the P. That is RP, long RP tachycardia, but P is inverted here. So these are by location. These are the groups of the tachycardias. We have to see. We cannot see. We may not see the P wave. That is, there is no P wave. P wave just after QRS complex. That is RP is less than 80 milliseconds. P wave is further away from the previous QRS complex. That is RP is more than 80 milliseconds. Or P wave may be situated just before the next QRS. That is, but it may be positive. So these are the groups of the locations of the P waves that helps to diagnose the supraventricular tachycardia. So this is an important slide that was shown by Dr. O.P. sir in the previous lecture. And so by summary, what we can see, there may be no P wave. Examples are the AVNRT or junctional tachycardia, or maybe upright P wave just before the next QRS complex. This is the example. That can be a case of the sinus tachycardia or sinoatrial reentry tachycardia or atrial tachycardia sometimes, or P wave may be retro P wave maybe just after the QRS complex like this. When the RP, that is the RP interval is less than 80 milliseconds, it is AVNRT like this. It is the AVNRT most likely. Or when the RP interval is more than 80 milliseconds, it can be AVRT like this. Or sometimes it can be the junctional tachycardia as well. And long RP tachycardia, these are the long RP tachycardia. That is one group. This is one group where the examples are like this, or this is another group where the examples like this. That is the atrial tachycardia or atypical AVNRT. So by location of the P wave in relation to the QRS complex has got tremendous role for classifying supraventricular regular tachycardia, what it can be. This is an example of the regular narrow complex tachycardia where heart rate is 150, it is regular. This is the location of the P wave, that is the P is positive and just before the QRS complex. So by definition, this is the long RP tachycardia, that is RP, that is the long RP tachycardia. And these are the differential diagnoses, that is the sinus tachycardia, atrial flutter, atrial tachycardia, AVNRT or AVRT. All we can consider as the differential diagnosis in such type of the narrow complex regular tachycardia. But what is actually it is, as because it is the sinus tachycardia, as because the P wave is situated just before the QRS complex and P wave is positive and the PR interval is more than 120 milliseconds. If it were less than 120 milliseconds, we should consider other diagnosis. But as it is more than 120 milliseconds, this is the classic example of the sinus tachycardia. So sinus tachycardia is one of the example of the regular supraventricular tachycardia. This is one of the examples of the long RP tachycardia, and the main characteristics of the supraventricular tachycardia is the location of the P wave. That is, the P should be in front of the QRS complex. That P must be positive in at least lead 2, and the PR relation is usually more than 120 milliseconds. So this is the sinus tachycardia, but these are the differential diagnosis. Academically, you can say these are the differential diagnosis, no problem. This is another example where this is the narrow-complex regular tachycardia. This is the regular narrow-complex tachycardia, and the other one is the irregular tachycardia. In case of the regular narrow-complex tachycardia, the classic example is the paroxysmal supraventricular tachycardia, as we know. And this is another group of the tachycardia. There's irregular narrow-complex tachycardia. So this is the way, simple way to classify the narrow-complex tachycardias into two groups, that is the regular and the irregular. The examples of the irregular tachycardias are usually atrial fibrillation, atrial tachycardia, or the atrial flutter with a variable block. So the narrow-complex irregular tachycardia, again, by this way, whether it is regular or irregular, we can classify and we can pinpoint the diagnosis toward the diagnosis, going toward the diagnosis, what it can be. That is the regular and the irregular. And this is the inside of the heart. This is the atrial area. This is the sinus node. This is the atrioventricular node. These irregular tachycardias are usually originated from the atrium, and the regular paroxysmal supraventricular tachycardia are usually originated from the nodal area. That is the AV node. So this is the way, that is the nodal tachycardias are usually regular, and whether their P waves can be seen or not, these are the regular tachycardias. And atrial tachycardias, in some ways, whether it is atrial fibrillation or atrial tachycardia or atrial flutter with the variable block, in some ways they show their irregularity. So this is the way we can also analyze the substrate of origin of these groups of the tachycardia, whether it is the atrial or the nodal areas. In this picture, you can see this is the tachycardia circuit within the AV node. This is the re-entry of the impulse, that is the re-entry circuit of the impulse. The impulse is coming from the atrium towards the ventricle and again from the ventricle to the atrium. So you need the two pathways from atrium to the ventricle and again from the ventricle to the atrium. And depending on these pathways, that is which pathway the tachycardia should utilize. The pathways are one is the slow pathway and another is the fast pathway. So which pathway tachycardia utilizes, that determines where should be the P wave location. Either the tachycardia, the antegrade pathway may be slow and the retrograde pathway may be the fast, or the antegrade pathway may be the fast or the retrograde pathway may be the slow. And depending on this, that is pathway utilization for the antegrade and the retrograde conduction, and that determines the location of the P wave, whether the P wave will be very much close to the previous QRS complex or the P wave will be just before the next QRS complex. So this is the types of the tachycardia, and this is the location of the P wave. In case of the slow fast atrial tachycardia, this is the location of the P wave just after the QRS complex. That is, the retrograde P wave takes only very short time to come into the atrium from the ventricle. So this is the location of the P wave, and this is the typical example, that is the examples of the typical or common atrioventricular nodal tachycardia. And here the P waves takes the longer time to come into the QRS complex. That is, it is located as the retrograde pathway is from ventricle to the atrium is slow, so it takes longer time from ventricle to the atrium to come. So it is situated just before the next QRS complex, and it is coming from the ventricle to atrium as because these are the inverted. So this is the long RP tachycardia. The P wave is retrograde, and this proves this is one of the example of the long tachycardia, and this can be happen in case of the atypical AVNRT. And this is the inside of the heart. We can see the location of the AV node. This is the septal leaflet of the tricuspid valve, and this is the upper part and this is the lower part. This is the ostium of the coronary sinus, and as because the AVNRT, it needs two pathways. One pathway is slow and one pathway is fast. As for example, this is the anatomical location of the slow pathway that is in this figure. This is the lower part of the AV node, The AV node is situated in the triangle of the Koch, that is bounded anteriorly by the septal lift of the tricuspid valve, behind by a ligament from the upper part from here to the IVC, and the apex is formed by these two, and the base is formed by the coronary stem. So this is the anatomical location of the AV node at the lower part of the atrium, right atrium at the septal aspect. So this is the location of the AV node, and at its upper part situated the fast pathway. The fast pathway is situated here, and slow pathway is situated the lower part. So there is physiologically two paths. That is the upper path, that is the fast pathway, and the slow pathway. And these two pathways connected proximally at the apex and distally by the physiologically. So it fulfills the criteria of the re-entry. That is, it fulfills the criteria of the re-entry, which includes it needs the two pathways of 2 degrees of conduction. That is, one is slow conduction and one is the fast conduction. These two pathways should be connected at either side. So it fulfills the criteria of the re-entry. So this is the basic criteria of the re-entry, and this is the basic criteria of the re-entry mechanism in the case of the AV nodal re-entry tachycardia. And there are two pathways situated in the AV node. That is, one is the first pathway and one is the second pathway. And this is present in nearly about 35% of the population, but not all person who has got the fast and slow pathway can presented with the supraventricular tachycardia. Supraventricular tachycardia needs some other criteria to be presented. So this can be present in case of nearly as much as up to 35% of the population. But for the re-entry to happen, it needs two pathways. That is, one is the fast pathway, one is the slow pathway in case of the AV nodal re-entry tachycardia. And the circuit is formed by the upper part is by the atrium, then the node, and this is the ventricle. So this includes the circuit. The circuit includes all the three structures. That is, three structures are required for the re-entry to happen in case of the AV nodal re-entry tachycardia. But because the tachycardia circuit is situated within the node, so it is called the AV nodal re-entry tachycardia. And this is the fluoroscopic view. We can see this fluoroscopic view. This is the catheter. This is situated at the upper part of the AV node, that is near the first pathway, and this is lower part, that is the slow pathway. So there is physiologically at least two pathways in case of the AV nodal re-entry tachycardia, and this is the basic mechanism of the AV nodal re-entry tachycardia. And this concept is required to analyze where should be the P wave location, as because in this example, this is the ECG. Here we cannot see the P waves. This is the regular narrow complex tachycardia, but we cannot see the P wave. That is, P wave is within, where it is the P wave? The P wave is within the QRS complex. And this is the tachycardia, the P wave is just after the QRS complex. Just after the QRS complex. There is no P wave, and this is the P wave location. Here, this is the P wave location that gives rise to the incomplete RBV pattern in the V1. This is one of the examples, that is the pseudo R in case of the AVNRT. So this is the P wave location, and this is the again the P wave location in the inferior lead. This is the retrograde P. This retrograde P is inverted in case of the 2-3 AVF. So this is the P wave location. This is the P wave location. That is the inverted P wave just after the QRS complex within the two small square. That is, the interval from the R to P is less than 80 milliseconds. Here again, R to P is less than 80 milliseconds. So P wave is situated just within the 80 milliseconds from the previous QRS complex. The P wave is inverted. That means the P wave is, that is the retrograde, and this explains that is the AVNRT. So AVNRT may be either there should not be any visible P waves. There is the P wave may be within the QRS complex, or P wave may be just after the QRS complex. But what determines that is whether the P wave will be the within the QRS complex or just after the QRS? What factors determines? It is the exit of the QRS complex. That is the exit. That is the exit of the P wave. Exit of the P waves from the that is the circuit. That is the circuit is that is the re-entry circuit is within the AV node. It has got exit below to the ventricle and above to the atrium, and it is the relation of the exit from the ventricle to the atrium that determines where should be the retrograde P wave. If the exit is simultaneous, that is the exit into the ventricle and the atrium is at the same time, there should be no QRS. But if the exit is little After the that is QRS complex, that will determine the location of the P wave. As for example, here the exit of the retrograde P from the AV node to the atrium is just within the 80 millisecond, not at the same time, but within the 80 millisecond of the QRS complex. So this is the location, and this determines the location of the P wave in the ECG, where it should be. And this is the classic. There is no should not be two different. We can academically conclude some differential diagnosis. All the differential diagnosis, that this can be AVRT, this can be atrial tachycardia, it can be junctional tachycardia. But classically, when there should not be visible P wave, it is almost certain we are dealing with the AVNRT. And when the P wave should be just after the QRS complex within 80 milliseconds, again we should think that we are dealing with the AVNRT. So these are two examples of the AVNRT where it can be. This is called the pseudo R and this is called the pseudo S. These are the two characteristics of the AVNRT. And this is one of the proof we can see in the EP lab that both the atrium and ventricle are contracting simultaneously. This part of the ECG during the sinus rhythm. Dear participant, you can see this is the P wave and this is the QRS complex. This is the P wave and QRS complex. That is P, that is the QRS complex after the P wave. But here we can see both the P and QRS complex are at the same time. That is simultaneous activation of both the atrium and ventricle. That is P wave is within the QRS complex. You see, this is the QRS complex and this is the location of the P wave. That is P wave is within the duration of the QRS complex. Here in this case, we cannot see the P wave with the 2 lead ECG. So this is the proof that the P wave, that is both the atrium and ventricle are activating simultaneously by the re-entry circuit within the AV node. And this is one of the definite proof that this can be a case of the AV nodal re-entry tachycardia. There are some differential diagnosis, but this is the classic example of the AV nodal re-entry tachycardia. In this case, we will not see the location of the P wave. So in summary, in case of AVNRT, the P wave location can be like this. That is, there may not be visible P waves, or if P wave is present, it is always inverted in case of the 2, 3 and AVF, as because the P wave is retrograde from AV node into the atrium, or it can produce, that is this retrograde P wave can give rise to the development of the pseudo S in lead 2, 3 and AVF, or it can give rise to the development of the pseudo R in lead V1, or in case of the fast slow AVNRT tachycardia, if the retrograde pathway is slow, it will take longer time, and at that time the P wave may be just before the next QRS complex, that giving rise to the long RP tachycardia, what happened in case of the atypical AVNRT. So this is the P wave summary of analysis in case of the AVNRT. These are the examples where should be the P wave location. This is another examples of the narrow complex regular tachycardia. You see, this is the narrow complex regular tachycardia, and this is the R and this is the P in case of the lead V1. You can see this is the R and this is the P, and the R to P is 1 to nearly about more than 3 small square, that is more than 120 millisecond. And again, there is some unusual morphology of the T waves in case of the lead 2. So there should be the presence of the P wave that can give rise to the such type of the T wave morphology in case of the lead 2. So, but whatever may be in the lead 2, we can see clearly that is the location of the P wave in case of the lead V1. So this is the short RP tachycardia, RP, short RP tachycardia. But although it is short RP, but still the RP interval is more than 120 millisecond. This cannot be in case of the AVNRT, as because in AVNRT, the P wave should be within the QRS complex or within the 80 millisecond from the previous QRS complex. So this is the example of the AVRT, atrioventricular re-entry tachycardia. Dear participant, AVRT, atrioventricular re-entry tachycardia. Simply we can call the AVRT. So this is the AVRT, where the location of the P wave from the previous QRS complex after the 80 millisecond, usually it should be the AVRT. So this is the example of the AVRT. And in case of the AVRT, this is the re-entry circuit. That is, one is the antegrade pathway, usually the normal conduction system, that is his frequency system. This is the AV node. This is the bundle of His. This is the left bundle. This is the right bundle. This is the normal conduction system, and this is the retrograde pathway. Usually, the accessory pathway is the retrograde pathway. Inverse may be true. That is the antegrade may be this way, retrograde may be this way. That will give rise to the orthotropic tachycardia, that is antitropic tachycardia. That will be described in another class just after uh, 2 weeks. So I will not discuss that issue later today. But for the analysis of supraventricular tachycardia, this is the atrioventricular re-entry tachycardia. This is the re-entry circuit, and the circuit starts from the atrium, going to the ventricle, and again back to the atrium through the accessory pathway. So this is the atrioventricular re-entry tachycardia. So the tachycardia circuit needs atrium to ventricle, usually by the slow pathway, that is the normal His-Parkinson contraction system, and ventricle to atrium, usually faster pathway, that is more faster than the normal His-Parkinson system. This is faster in relation to the normal contraction system. So this is the faster pathway. So it has got again fulfills the re-entry criteria. That is, it has got the two pathways. One is slower, that is the normal His-Parkinson system. Another is the faster, that is the retrograde contraction system, that is connected above at the atrium and connected below at the ventricle. So it fulfills the criteria of the re-entry circuit. So this is the re-entry tachycardia and example of the atrioventricular node re-entry tachycardia. And the ECG of these kinds of the tachycardia, that is the sinus, that is the resting ECG, either maybe this type or maybe this type. If the conduction, this is the accessory pathway, if the accessory pathway conducts antegradely during the sinus tachycardia, that is the sinus rhythm, along with the His-Parkinson system, it will produce the delta wave. This is the delta wave. So this is the example of the these are the delta waves, that is the classic delta wave. This is produced when this impulse is conducted both through the accessory pathway and through the normal conduction system from atrium to the ventricle. So this is the example of the delta wave, and we can see it in the sinus rhythm. But when this accessory pathway conducts only retrogradely from ventricle to the atrium, not from atrium to the ventricle antegradely, then there will be such type of ECG. We will not see the delta wave. So these kinds of the is called the concealed pathway. So the pathway, that is the sinus rhythm. But whatever may be the pathway, either it is manifest or it is the concealed, this will give rise to the development of these types of the tachycardia. These are the narrow complex tachycardia that can happen in case of the atrioventricular re-entry tachycardia. This is the location of the P wave. This is the R and this is the P. This is the R and this is the P. The P wave is retrograde as it is inverted. Here you can see also suspect this may be the location of the P wave, here, here or here. So these are the short RP tachycardia, that is RP is shorter than the PR. This is the short RP tachycardia, but the interval from the R to P is more than 80 milliseconds. So this is the narrow complex regular short RP tachycardia, but the R to P is more than 80 milliseconds. So this can be, this should not be in case of the AVRT. This can be example of the AVRT, and sometimes in case of the AVRT, particularly this type of the AVRT, that is the paroxysmal junctional re-entry tachycardia, the P wave may be just before the QRS complex, giving rise to the long RP tachycardia, that is R and the P, and this is the P to the R. So RP is longer than the PR, so long RP tachycardia. So the whatever may be the AVRT, that is the sinus rhythm, either delta wave present or not, the ECG presentation of AVRT would be like this: short RP tachycardia, but after the 80 milliseconds, or the long RP tachycardia just before the next QRS complex. But this P wave should be inverted. This should not be the positive, as because the atrium is activated from ventricle to the atrium by the retrograde wave. So this should be the inverted P wave, and this is the determinants of location of the P wave, as because this is the location of the QRS complex, and the exit of the P wave depending upon the location of the accessory complex, that will be described in another session. That is, it can be exit to the atrium maybe here, or maybe here, or maybe here. So the location of the P wave in relation to the QRS complex is not fixed. It can be just at the close to the QRS complex, just after the QRS complex, or significantly after the QRS complex, that is the next, before the next QRS complex. So these are the factors. That is the location of the that is the atrial insertion site of the accessory pathway, and the speed of the conduction from the ventricle to the atrium from the accessory pathway, that determines what should be the P wave location in the ECG. So these are the determinants of the P wave location. That what is message is that the P wave location is not fixed. The P wave should be inverted, and P wave should be seen particularly just after the QRS complex on the segment of the ST segment or before the next QRS complex, and giving rise to the either short RP or the long RP tachycardia in case of the AVRT. And this is another example. Here we can see this is the location. This should be the location of the P wave, but this ECG again, if this is the location of the P wave, this is the location of the P wave, we can see this is an example of the AVRT. But again, from the 12-lead ECG, the location of the P wave in case of the V4, V5, and V6 is inverted. That is the retrograde. And as the impulse is going away from this location, that is inverted in case of the V4, V5, and V6. This can be a case of the accessory pathway situated at the lateral side. That may be that is the accessory pathway, left lateral type of accessory pathway. That will be discussed in the another session. But clue is that even in case of the AVRT, by analyzing the narrow complex regular tachycardia and assuming the location of the P wave, inverted P wave, we can suspect what should be the location of the P wave, that is accessory pathway in case of the of that patient. So this is another example. These are the differential diagnosis. We should always consider these groups of the differential diagnosis in case of analyzing the narrow complex regular tachycardia. But whatever the differential diagnosis, this is an example of the AVRT, that is atrioventricular tachycardia example. This is another example, that is this is the long RP tachycardia, RP. So this is the example of the long RP tachycardia. This is the narrow complex regular tachycardia. But other than the P wave, something else we have to see for analyzing. What is the striking feature in this ECG? Dear participant, I think you can see the amplitude of the QRS complex are not fixed. One QRS complex amplitude is larger and small, large and small. This is called the QRS alternance, electrical alternance. So presence of the electrical alternance in case of the narrow complex regular tachycardia is a diagnostic for the accessory pathway. This can be happen also in case of the AVRT, as because in case of the atypical AVRT, this is not 100% proof, but this gives some clue that is more likely to be the AVRT because of the presence of the accessory, that is the QRS alternance, more than the atypical AVRT. This is the long RP tachycardia. It may be in case of the fast slow, that is antegrade pathway is fast, retrograde pathway is slow in case of the AVRT, but it is more likely AVRT, as because the electrical alternance is particularly a function of the heart rate. The greater the heart rate, there is the more chance of developing the QRS alternance, and it is the function of the re-entry. Any kinds of the re-entry tachycardia can give rise to such type of QRS alternance, but it is commoner in case of AVRT than the AVNRT. So this should be a case of the AVRT, but this type of the QRS alternance also we can see in case of the sinus rhythm. If it is present in case of the sinus rhythm, that gives some other clues of diagnosis, particularly the cardiac temporate and the cardiomyopathy. So QRS alternance, particularly the amplitude of the QRS alternance during the narrow complex regular tachycardia, more likely AVRT than the AVNRT, but during the sinus rhythm, this should be a case of the cardiac tamponade or the cardiomyopathy. That is the heart failure particularly. This is the another issues that we have to consider for analyzing the supraventricular tachycardia other than P wave. What is the hallmark in this ECG? This is the narrow complex regular tachycardia. That is the narrow complex regular tachycardia. This is the supraventricular tachycardia. The hallmark is the ST depression, gross ST depression, all the leads, and even the ST elevation in case of the AVR. And easily we can see This can be a case of the left vein disease. Particularly, our Professor Abdul Chaudhary will be happy to diagnose it. There is a left vein disease, as because there is ST elevation, gross global ST depression, or the ST elevation in case of the AVRT. But other than the POF, other than the QRS alternates, this is another important clue for analyzing the regular neurocomplex tachycardia. And this ST depression, although this patient may have the concomitant coronary artery disease, but it does not need to happen. It is the characteristics of the AVRT, that is atrioventricular reentry tachycardia. If this type of the ST depression is present, the more chance of having the AVRT, that is atrioventricular reentry tachycardia, than the AVNRT. So QRS alternates and ST depression are two other additional points other than the POF that we have to analyze for diagnosis the paroxysmal supraventricular tachycardia. So in summary, these are the some points, that is the presence of the pseudo R or pseudo S, ST depression, ST elevation in AVR, retrograde POF on the ST segment, at the ST segment or beginning of the TOF, or QRS alternates. These are the sum of the points that we have to consider for differentiating between the AVNRT or AVRT that I have already discussed. So other than the POF location, POF morphology, and the POF axis, these are the points that you have to consider for the differential diagnosis of the AVNRT or AVRTS, because these two are the more common tachycardia. But in addition to these kinds of the modalities, sometimes application of the adenosine can help to diagnose these kinds of the neurocomplex tachycardia. This is the regular neurocomplex tachycardia, but application of the adenosine clears, that is the rate of the PFDL is 300. So this is the adenosine that helps to differentiate these kinds of the regular neurocomplex tachycardia. That's the example of the atrial flutter. And this atrial tachycardia, that is this regular neurocomplex tachycardia, terminates in the sinus rhythm. This is the POF, this is the POF, this is the POF, that is sinus rhythm. That is termination of the tachycardia and clearing of unmasking the POF, that helps to differentiate what it can be, either the atrial tachycardia or the AV nodal dependent tachycardia. And by this way, by application of the adenosine, we can differentiate, we can classify the neurocomplex regular tachycardia is nodal dependent, like the AVRT or AVNRT, or nodal independent, that is not dependent on the AV node, like this example, that is the atrial flutter or atrial tachycardia or atrial fibrillation. And but there are some cases where this is the way of differentiating these groups of the tachycardia into the either whether it is AV node dependent or AV node independent. But not always adenosine can terminate this tachycardia. This is one of the example. This is one of the example of the long IRP tachycardia. I have already shown this ECG. This is the example of the long IRP tachycardia. This type of the tachycardia, sometimes where we can see, particularly in case of the children or adenosine, even after application of the adenosine, the tachycardia terminates, but again, within few seconds or minutes, it again starts. Again terminates, again starts. Even after the DC shock, the tachycardia terminates, again starts. That is this type of tachycardia, the incessant tachycardia. This is particularly happens in case of the PJRT, paroxysmal junctional reentry tachycardia. And this is one of the example of the tachycardia. And these are the differential diagnosis point. But if adenosine does not work, DC shock does not work, it is more likely this is the PJRT, paroxysmal junctional reentry tachycardia, as because this is, we are not always thinking this type of the tachycardia, as because this is unusual form of the AVRT, where the retrograde path is very slow, as because it is very slow. So the location of the POF is just before the next QRS only. If the retrograde path should be faster, the POF should be here. But if the retrograde path is slower, so POF location is here. So this is the unusual form of the AVRT, and this is the commonest cause of the incessant tachycardia in children and the adolescent. And re-entry is the mechanism and less responsive to the adenosine. And this is the one of the common example that gives rise to the development of the tachycardia induced cardiomyopathy. But we are not considering differential diagnosis in the adult, as because this is not a common tachycardia. So it is less, that is, we think it when these kinds of the characteristics we can see, that is, it does not respond to the tachycardia. But this is not unusual, this may happen. So this is one of the example of the long RP tachycardia. And these are the characteristics of the PJRT that is considered in case of the long RP tachycardia. And in case of the junctional tachycardia, not always this is the re-entry tachycardia. This is the example of the what we mean by the AV junction. This is the common thing we should consider. Atrioventricular junction. What do we mean by this? That is atrioventricular junction means the AV node, that is atrioventricular junction, has got the three parts. The atrial part here, this is the middle part of the compact AV node, and the distal part. So all these structure consider the AV node, that the atrioventricular junction. And this tachycardia from here sometimes may give rise to these kinds of the, that is paroxysmal junctional tachycardia, and not always. Most of the time, the rhythm from here is the junctional escape rhythm, that is 40 to 60 beats per minute. This is the inherent junctional, that is the rate, that is the junctional escape rhythm like this. This is the junctional rhythm, and this is the normal rhythm of the junction, as because this is the rate, it is about 40, and this is the location of the P wave just after the QRS complex. So this is the junctional escape rhythm. This is not the tachycardia or the bradycardia. But when the rate goes above the 60, this is called the accelerated junctional tachycardia. This is tachycardia for these kinds of the rhythm, as because its inherent rate is 60. So more than 60 is accelerated. But when the rate goes beyond more than the 100, then it is called the junctional tachycardia. So the junctional rhythm can be from either parts of these three parts of the AV node, and these are the examples of the rhythm what can be arises from these kinds of the tachycardia, but not always. This is the re-entry tachycardia. Sometimes it is the junctional rhythm, sometimes it is the accelerated junctional rhythm, or sometimes it is the accelerated junctional rhythm, or sometimes it can be the junctional tachycardia. And this junctional tachycardia, either it may be automatic or it can be paroxysmal. And this paroxysmal, the automatic, usually does not fulfill the criteria of the re-entry. And as it does not fulfill the criteria of the re-entry, this is the reason why it does not respond to the adenosine. So long RP tachycardia, non-responsive to adenosine gives rise to the suspicion of the PJRT, and PJRT is the tachycardia that is arises from the atrioventricular junctional area. And this is another example of the supraventricular tachycardia. There is the regular wide complex tachycardia. So this is the example of the wide complex tachycardia. Supraventricular tachycardia may be presented with this type of the ECG, and in case of the supraventricular tachycardia, most of the time it is due to the aberration of the QRS morphology, and aberration of the QRS morphology either may be functional because of the partial refractory phase of the either of the pathways, usually the right pathway, as it is the narrower than the left pathway. This is not the anatomical block, or two anatomical block may be present. There is the two anatomical block may be either in the right bundle branch or left bundle branch. So supraventricular tachycardia again may be presented with these kinds of the ECG, that is regular wide complex tachycardia. I will not discuss this issue, as because wide complex tachycardia will be discussed by Dr. Rafiq Ahmed in this Saturday, that is on the 19th of this month. So this is the very important topics, that is differential diagnosis of the wide complex tachycardia. This is a topic for our Rafiq Ahmed sir, that will be happening just after the Saturday after next. So I'll not discuss this issue. So these are the examples of the different kinds of the supraventricular tachycardia. So ECG is not the only means to diagnose the supraventricular tachycardia. There are other means. That is the pharmacological means, as I have discussed, like the adenosine, or there will be some vagal maneuvers that also help to differential diagnose that is the supraventricular tachycardia, or sometimes we use the pacing maneuvers. Unlike we use the pacing maneuvers in the EP lab, we cannot definitely diagnose the supraventricular tachycardia. So ECG is not the final means. We should not consider ECG is the only way for clean cut confirmed diagnosis of the supraventricular tachycardia. Many of the times we need these types of the help. So this is not the ECG that will give all types of the answer, but ECG is very much important for the differential diagnosis and initial, that is index of suspicion for the differential diagnosis of that. But most of the times it is possible to diagnose the what types of the supraventricular. But sometimes This not always. This is the examples in few cases. So in summary, supraventricular tachycardia is a very common arrhythmias. Its prevalence is nearly 35 per 100,000 people. So this is not uncommon tachycardia. And very interesting, this is a disease of the healthy people. Actually, most of the healthy people are presented in these kinds of the tachycardia. And another important information, this most of the time this is a curable disease. So we should diagnose it. This is the reason we should diagnose clearly these types of the tachycardia. So we should not avoid the diagnosis of this tachycardia. But this is not all about this tachycardia. There are many things to know and more in the next time. Thank you very much for your kind participation. Thank you.
Thank you, Atar Bhai. I think with each lecture, I come to understand how little actually I know each time. Sometimes I get a little bit depressed. There's so many factors, so many information. Can I remember all that? But the most important thing is perhaps treatment-wise, for a group certain type of tachycardia, you take up a certain type of treatment, you achieve the success. And then analyze which type of tachycardia it was. Firoz, দেখো তো
Sir, there are good number of questions. Some of them are being already answered by Dr. Rafiq Ahmed, sir. Should I repeat these questions, sir?
why not? Reciprocation better.
Okay. Okay, sir. Sir, one question from Dr. Rehan. In atrial fibrillation, no P wave, but how P rate calculated? Atar, sir.
I think Rupik Ahmed sir is here, sir.
No, Athar, please answer that. Yeah.
Yes, sir. Actually, the fibrillated wave, it is difficult, but sometimes we can see, not always, the fibrillated wave may be the very fine fibrillated waves or the coarse fibrillated waves. This is not always possible to calculate the rate of the fibrillated waves, but sometimes it is possible if the fibrillated waves are organized. That is, it depends on the morphology of the fibrillated waves, whether it is very fine. If it is very fine and difficult to see, then it is not possible. But if it is organized, then we can calculate the fibrillated, that is the rate of the tachycardia. And as these are not regular, so we should calculate the number of the waves in 10 seconds or like this. Then we can multiply this interval into the convert it into the 60 seconds. This is the way we can consider that is calculate the number of the fibrillated waves. But this is not always possible if we cannot see the fibrillated waves clearly.
Can I add something?
Yes.
Nice.
Actually, when we say the P wave here, we do not mean the sinus P wave. Any atrial depolarization wave, we call it P wave. But is it sinus P wave? Is it junctional P wave? Is it flutter wave? Actually, we mean that it's an atrial depolarization wave. That's what actually Atar Bhai was saying. And you can only assume the rate if this is coarse atrial fibrillation. Otherwise, fine atrial fibrillation is very difficult. And only the EP persons like you can actually determine that from the study.
Yes, it can be determined from intracardiac tracing.
Cardiac electrocardiogram.
Easily it is countable, but from surfaces it is very difficult to count the rates.
True. Yes.
Rafiq sir, do you want to comment on that?
No, I think Jamil and Athar answered the question, and there is no point of even trying. I mean, intracardiac we can, but the rate is so fast. The rate varies between 500 to 700 beats per minute. Once it is atrial fibrillation, there is no point of saying that P wave rate is such and such.
Yeah.
Thank you, sir. Next question: if in atrial flutter with 3:1 or 4:1 conduction, QRS complex rate is less than 100, is it tachycardia? In a patient with atrial flutter with 3:1 or 4:1, the atrial rate is more than 100, but the ventricular rate is less than 100. Should we call it tachycardia?
So it is by definition, this is the atrial tachycardia. This is the atrial tachycardia is because this is atrial flutter is an example of the atrial tachycardia where the flutter rate is more than 100, usually 300 plus minus 50. But the ventricular response may not fulfill the criteria of the tachycardia is because ventricular response may be depending upon the block in the LV node. As for example, if it is 2:1, it may be 150. It is 3:1, like this. So it should not be mentioned that it is tachycardia. It is atrial flutter. You should just mention it is atrial flutter with this type of the ratio. That is either fixed block like this 2:1, 3:1, or 4:1, or the variable block like this. And again, you can add the adjective like this: the ventricular response is fast or ventricular response is slow. So I think this term is not applicable for the ventricular rate. This term is applicable for the atrial rate, that is the flutter rate that fulfills the criteria of the tachycardia, that is the more than 100, and it is 300 plus minus 50.
Actually, when we say tachycardia or bradycardia, we actually mean according to the ventricular rate. That's important for our clinical context. But for the etiology, from the ECG, we do not mean that atrial tachycardia. We call that atrial tachycardia means the rate is high, and that's from atrial rate is high, particularly from the atria. Flutter rate is also high from atria. Fibrillation rate is high from atria. But ventricular rate, we mentioned that separately. And he's very right.
As we say in case of atrial fibrillation, the AF with first ventricular rate, AF with normal rate, AF with slow ventricular rate, response like.
Thank you, sir. Dr. Rafiq, sir, do you want to add anything, sir?
No, I'm fine with that. But there's a question about electrical alternates.
Yeah.
Yes, sir. Yes, sir. I'm coming there.
Yes.
Sir, there's a question by Dr. Kurmi. Features of Mahim fiber tachycardia. Atar sir, do you want to answer this question?
Actually, this is the issue that will be discussed in the next lecture, that is about the accessory pathways.
Okay, sir. Okay, sir.
Yeah.
Another question by Dr. Rehan. Long RP means more than 80 millisecond or more.
No.
What does exactly long RP means?
No. Long RP means it is the interval from the previous QRS to P, and P to the next QRS. It is the ratio between these two. The P wave may be at the middle part of the both QRS complex. There is a RP maybe that is at the mid part of the QRS complex. That is a RP may be equal to the PR. So it is a it is a ratio, that is a R to P and the P to R. So this is the way how to differentiate with the long RP and the short RP. If the R to P is longer, then it is called the long RP. But most of the time, except in case of the sinus tachycardia and atrial tachycardia, the P before the next QRS is inverted, and that implies most of the, if it is inverted, we are happy, that is, it is not the sinus tachycardia, this is the retrograde P wave, either maybe AVRT, atypical AVRT, or the atrial tachycardia. If the P wave is inverted, particularly in case of the lead 2. So, but when it is P wave is positive, particularly in case of the lead 2, and just before that tachycardia, by definition, this is example of the long RP tachycardia, and sinus tachycardia is the best example. Sometimes atrial tachycardia may happen. So it is the R to P and P to R.
Thank you, sir. In AVRT, P always negative, or it may be positive also?
AVRT P.
In AVRT, is P always negative, or it may be positive also?
As most of the time, as because AVRT, this is also will be discussed in the next session. But in case of the AVRT, the tachycardia may be antidromic or the orthodromic. Orthodromics means the antegrade pathway from the atrium to the ventricle through the normal conduction system, and the retrograde pathway from ventricle to the atrium, that is from below upwards, that is retrograde way from ventricle to the atrium, that is the retrograde pathway. So in this case, their P must be the inverted, that is the negative. So in case of the orthodromic AVRT, it must be negative. But in case of the antidromic, if it can be seen, yes, there maybe it can be positive. But most of the time, the presentation of the AVRT is orthodromic, narrow QRS, and the T is inverted classically.
Thank you, sir. Dr.
I
Rehan
just make a comment.
Sure,
Just a
sir.
brief comment. So
Yes, sir.
what Athar said, I'm just going to make it a little simple. If the reentrance circuit and the activation of the atrium is coming from below, that means either from AV node reentry or atrioventricular reentry, the electrical signal will move from inferior part of the atrium to the top part. So the leads that are going to be negative will be leads 2, 3 AVF in all cases. In other situations, it will be variable, like Athar showed in ECG, possible left lateral accessory pathway. In that case, it will be negative in V6. But all these re-entrant tachycardia plus an inferior atrial tachycardia will have negative P wave in leads 2, 3 AVF. Please do not confuse it with negative in all leads.
Thank you, sir.
Thank you, sir.
Thank you. Dr. Rehan asked a question. He confuses P wave, that is inverted P wave, with T wave frequently. How we can differentiate these two things? The P wave after R wave, which is often inverted, and it is confusing with T wave. How to differentiate this P wave and T wave?
Can I answer that?
Yes, sir. Yes, sir. I'll be happy, sir.
Yeah, I get confused too. So the answer is yes. So the whole point is that you come up with a presumptive diagnosis. Like if the P wave is really overlapping on the T wave, you can't see it. I mean, you can be the best scholar, best electrophysiologist in the world, but you will not see it. You cannot make something like. So yes, this is confusing for all of us. What we try to do is Athar showed an ECG where in V4, V5, V6, there was some distortion of the ST segment. And he made an assumption that was the P wave. And the way we find the P wave is we look at multiple tracings. See, yes, I can see it all the time. It's not an artifact. That's what it is. And then I get confused too. I'm sure all of us get confused.
Yes, sir.
Thank you, sir. Dr. Hiru Alamin asked, when we tell paroxysmal supraventricular tachycardia, what is the definition of paroxysmal supraventricular tachycardia?
Paroxysmal means that is the onset of the tachycardia is sudden, all on a sudden, that sudden onset. And the tachycardia, how much, that is how long it will persist, that is not the question. When it terminates, it is again suddenly. That is sudden starts, sudden cut. This is the characteristic of the paroxysmal. So paroxysmal tachycardia, usually this is also a criteria for the re-entry. When the paroxysmal criteria fulfills, the mechanism is usually the re-entry tachycardia. Not always. There is some automatic tachycardia, as for example, the paroxysmal junctional re-entry tachycardia. Without re-entry mechanism, this may happen. But most of the time, classically, this is the re-entry mechanism, and sudden start, sudden off. This is the characteristic of the paroxysmal tachycardia.
Thank you, sir. Is it possible that AVRT becomes wide complex tachycardia?
Yes, AVRT. Both AVRT and AVNT, but most of the time it is the AVRT, then the
Yes, sir.
AVNRT that can produce the rate-related bundle branch block aberration. Yes, bundle branch block aberration is not uncommon in case of the supraventricular tachycardia, and it constitutes 15% of all the wide complex tachycardia that will be discussed in the next lecture by our sir. So yes, supraventricular tachycardia may be presented with the wide complex tachycardia, and it is most commoner in AVRT than the AVRT than the AVNRT.
No, thank you, sir.
To me,
there is a question like slow or fast pathway. Is it genetically determined, present in all patients, or only in pathological condition?
So I think I will happy Rupika sir answer to this question. But initially I will to talk as because I have shown in the lecture as because if we analyze these kinds of the physiology in the EP lab, it can be observed in nearly about 35% of the population. But all the population having these kinds of the dual physiology, this is the physiological concept, then the anatomical concept. But there is some anatomical consideration as because what I have shown in the location of the AV node, and the upper part shows the location of the fast pathway and the lower part is the slow pathway. But the concept is more physiological than the anatomical. And this concept, that is this kinds of the physiology may be observed in up to 35% of the population. But not all population having these kinds of the physiology will develop the supraventricular tachycardia. Sir, if we
Can I add something, Adar?
Yeah, sure.
It is more congenital than genetic.
Oh, yes,
It's,
congenital than the acquired,
it's
right?
congenital, not genetic.
Yes, sir.
Congenitally, there is a slow and fast pathway, and it is physiological, no doubt. There is no definite histological difference of the cells around the AV node, but it's not genetic. Rafik sir.
Yes, precisely the point that Dr. Jamil made. We have to be careful when we use the term genetic. Genetic will be long QT syndrome. That means if a patient has that, they can pass it on to their children. Avinodal dual physiology is the electrical phenomena, whether it's anatomic or not, that's a different story, but it is not genetic. People are born with it. And that's what we are trying to emphasize.
Thank you, sir. A question from Dr. Shahidul Bogra. How to manage a case of recurrent SVT in situ when adenosine fails? Athar, sir?
Yes, when adenosine fails, that again we have to review the diagnosis of this case, particularly as I have shown, as because there are some kinds of the tachycardia. Adenosine fails means in case of the narrow complex tachycardia, it may not be the AV nodal dependent supraventricular tachycardia. There are other alternative diagnoses you have to consider, as because although it looks like the supraventricular tachycardia, it may be atrial flutter, it may be atrial tachycardia, or it may be the paroxysmal junctional re-entry tachycardia, and these kinds of the tachycardia usually does not respond quite well to this adenosine. They respond, but again they can start the tachycardia. So we have to review the diagnosis again. But if the patient is clinically unstable, hemodynamically unstable, we have to think about the non-pharmacological maneuver, particularly the cardioversion, for the immediate safety of the patient. So if adenosine does not respond, we have to think even the administration of the adenosine, whether it is in the proper way or not. This is also a point we have to consider. So these are the things we have to rethink when adenosine fails to terminate the tachycardia.
Okay, sir.
Adenosine should be pushed
Sir.
very rapid. Otherwise, it is not going to work. Its half-life is very short.
Okay,
So
I think
bolus suddenly. It should be pushed to the intravenous and flushed with saline.
Okay, this is the point. I think Dr. Jamil is making a very, very important point. Is the common reason of failure of adenosine is how we inject it. The half-life of the medicine is 9 seconds.
Yes.
So let's say I have connected an IV syringe to an IV line. I inject the adenosine. I take that syringe off, then put another syringe and flush it. I have actually crossed 9 seconds.
Yes,
What I do is, first of all, put a 3-way stopcock.
Yes.
So in one syringe, there is 20 cc or 50 cc of flush. The other syringe is the adenosine. So you inject the adenosine and turn the quickly and then flush it fast. The other trick that we do is we lift the arm of the patient to make the drainage first. So if 6 milligram doesn't work, we give 12 milligram. Maximum, we rarely give 18 milligram. Now, once we give that, two things will happen. One, if it is a reentrant circuit, atrioventricular reentry or AV node reentry, there will be block in the AV node. And it will stop the tachycardia, most likely. If it is atrial tachycardia or atrial flutter with one-to-one conduction, it will block the AV node and we'll be able to see the flutter wave. And in that case, there is no point of trying it again. If the SVT stopped and started again, I may try one more time to see if it works. If then it does not work, let's say I have given adenosine, patient came back to SVT again after 2 minutes. I give second dose of adenosine, it comes back to SVT after 2 minutes. Am I going to give electric shock to that patient? Yes, I can. But if I do the electric shock, it will come back again. So then I will have to think of something that works. So I can put the patient on intravenous diltiazem drip. I can be careful about the blood pressure. Extremely rarely, if the patient is very sick, let's say somebody with septic shock, recurrent SVT, with a systolic pressure of 90 millimeter of mercury. And I gave adenosine, it stopped, it came back, or I gave electric shock, it came back. The only drug that you can start in intravenous amiodarone, because amiodarone will not change the blood pressure too much unless we give it bolus. So rarely, extremely rarely, we will use intravenous. So the sequence wise, first adenosine. If after adenosine there is recurrence of the SVT quickly, there is no point of trying to shock. I think we will have to then give intravenous diltiazem and then consider amiodarone. And the other thing is that if, of course, Athar mentioned that if the patient is hemodynamically unstable, then of course there is only one treatment of choice, which is electrical shock treatment. Please remember that you will not want to be shocked when you are awake. So please try to call anesthesia department and sedate the patient and then give electric shock. That's very, very important.
Thank you, sir. Next question, why electrical alternance occurs in AVRT?
Yeah, I wanted to touch that point. It's very,
Yes, sir.
what I do, I cannot remember things if I don't understand it. So electrical alternance is a vague phenomena, and the typical time that we find is in pericardial effusion. Why? Because the heart is floating in this fluid and it is changing direction, flip-flopping, and it's called rocking of the heart. And you get one QRS small, one QRS longer. Why will that happen in SVT? Nobody knows the mechanism. And also, why is it seen more in atrioventricular reentry than AV node reentry? So what they have said that maybe it is possible, I just imagine Athar's picture, that there is an accessory pathway on the left side of the heart. So electrical signal went back through the left side, came through the atrium and going down through the AV node. And that patient, by any chance, had a dual electrical system, and that goes through the slow pathway. Next time the signal comes, goes through the fast pathway. And the way this theory came about is if you carefully look at those electrical alternates, you will find that there is some variation in the RR interval. So that is the mechanism that has been postulated, that maybe this patient have dual physiology. It will, one signal goes through the fast pathway, conduct to the QRS, another slow pathway, the AV node, and that's why we see it more commonly in atrioventricular reentry and atrial tachycardia rather than AV node reentry. So these are all theories. It will be very, very tough, but this alternation in RR interval, you can actually map it. If you look at the ECG that Athar showed, and if you measure it, you may find that there is some variation in RR interval of that ECG.
Thank you,
I
sir.
think there are, what is the highest level of ventricular rate in sinus tachycardia, sir?
In case of the in case of
Yes,
the sinus tachycardia, that is, we can see what is happening in case of the treadmill test. There is the maximum sinus rate we calculate, that is a 220 minus the age. So theoretically, usually does not happen, but theoretically it is possible that is the sinus rate maybe goes up to that level, that is the age minus, that is a 220 minus the age. This can be, but usually it is the without during the stress test, normally physiologically it is not the rate. So I think upper rate, I don't know what is the answer, and Ruby sir may add something, but the maximum rate can be what we see in case of the stress test. There is 220 minus the age. That is the maximum predicted rate for an individual person. Is the chronotropic response is okay, sir?
No, I think you are absolutely right. I mean, during treadmill, we take patients to 100%, 110%, people who are athletic. You can go to 110% of age predicted maximal heart rate. So there is no limit to that. So by rate itself, we cannot differentiate it.
Thank you, sir. One of the question by Lieutenant Colonel Nizam. What is the treatment of paroxysmal junctional reentry tachycardia, as it is refractory adenosine and DC shock? I think, Athar sir, do you want to make any comment on this?
Yes, that is the most of the time it is difficult, even pharmacologically, and even that is by the ablation. This is a very difficult type of the arrhythmia to treat, but still it is the ablation that is the treatment of choice. Ablation is a treatment of choice for that is the curative treatment of choice for this paroxysmal junctional re-entry TKD. But this is always a very difficult TKD to treat. But this is the treatment of choice. Usually, drug works very little to this type of the TKD.
Regarding sinus tachycardia, there is a good question or comment by Dr. Ajay Datta. Why 220 is the magic number of maximum sinus tachycardia? In ETT or in other cases, we use the term number 220. Why it is 220? Rafik sir, please.
No idea. I don't know why they came that number
Wadud
from.
Chaudhary?
Wadud Meche.
Wadud Chaudhary is a master of this question.
And I could not find it. I'm going to ask that question. But usually we assume that most of the time sinus tachycardia do not exceed, most of the time, do not exceed 160, usual scenario, except in treadmill. So whenever it crosses 140, you have to be cautious whether it is actually a flutter with twist to one conduction or it is sinus tachycardia. That we have to be taking care of. One thing is that, for example, in a junctional paroxysmal tachycardia, it's very difficult. What drug are you going to use, Athar bhai?
So
I want to comment about
yes,
this.
sir. Yes, sir.
PJRT. PJRT is uncommon in adults.
Yeah.
It is more common in pediatric patients post-surgery.
Yes.
So it is more common in post-cardiac surgery in pediatric. In adults, when we call PGRT, we have to be careful that whether we are missing AV node reentry or not. It is possible that it's AV node reentry and we cannot see that. Treatment-wise, if you look at the junction, AV node is calcium current dependent. And if you want to choose a benign medication, it will be a calcium channel blocker. If you look at the AV node, there is some effect of the beta blocker. So we can try beta blocker, we can try calcium channel blocker. And then as Athar mentioned, that if all those fails, let's say somebody is 85-year-old or close to 90-year-old in this country, or in Bangladesh, 75, 80-year-old. And we believe that is really paroxysmal junctional tachycardia. And I have a choice, nothing works. I have a choice between amiodarone and going for an EP and ablation. Because what will happen with PJRT, that if once we try to ablate this patient, I am actually ablating the junction. There is high likelihood that these patients will end up in heart block. So the choice would be, am I going to take that risk or take the risk of a side effect of a drug like amiodarone? And these are a thinking process that we have to consider. First, we have to confirm that this is a junctional tachycardia without any re-entry circuit. It's not AV node re-entry tachycardia that is we are missing. So those are all the options that will. But in general, in my practice, I mean, we rarely see this pure paroxysmal junctional tachycardia in adults.
So one of the comment by Dr. Rohan is, should we use CV line for adenosine injection? So do you advocate?
The question is, so let's look at the scenario. A 32-year-old man comes to the emergency room. He is having palpitation. Blood pressure is 110/60. And I am that patient. And you want to put a central line in me? Question to, as a physician, I have to ask myself that if you say that I'm the best person who can put central line, and I'm going to put a central line in you, do you think I'm going to agree to that? Absolutely not. No, on the other hand, if somebody is needing a central line for something else, and there is already an existing central line, I will use that central line to inject it, but then I will reduce the dose by half. So we have to be careful. So no, I will not put a central line just for that. I think for any procedure that we do, I ask myself, every time I go to the room, I look at my patient, look at how many lines hanging from the patient's body. And I ask, am I going to use any of these lines today? If the answer is no, I'll take it out. Because the more line we put in any patient, the more infection risk there is. And this is actually one of the commonest cause of hospital-acquired infection, all these lines that we put in patients.
Atar bhai, can
Uh,
something to the,
Khaled Mohsin sir, please.
actually the misplaced central line is one of the cause of atrial arrhythmias, because if it goes down below, it will irritate the right atrium and cause some arrhythmia as well.
Very well.
hmm.
Thank you.
Thank you for the.
We have got Professor Mohsin Hussain with us. To Dr. Mohsin Hussain, please answer. What are the prophylactic drugs for recurrent SVT, and when we should refer a patient of SVT for ablation?
Prophylaxis mainly narrow complex tachycardia. If the patient does not have a documented atrial fibrillation, a choice of long-term prophylaxis usually verapamil, diltiazem, beta blocker. These are the commonly drug we can use it for long-term prophylaxis. If the patient has a recurrent symptom, then patient needs ablation. If the patient has minimum symptom once a year but twice a year, then we can patient and hypertension, we can keep this patient on drugs.
So we shouldn't refer on the first time for ablation on the first counter.
No,
first
first
contact.
time usually, if the first time the access pathway, if the and patient are high risk group, that is the patient is diaper, patient is what is called
high risk profession.
High risk profession, then we can ablate this patient. Otherwise, we can keep it.
Mohsin, let's say,
I want to add one thing.
yeah,
First time attack and the patient lost consciousness is an indication for ablation. Another thing is if it is in case of AVRT, if it is antidromic, then first attack is an indication for ablation.
Rafik sir, do you want to add anything, sir?
Well, this is a very, very important question. Let's say I am in the office and this patient comes and tells me he's 35-year-old, first episode of supraventricular tachycardia. He went to the emergency room, he got adenosine, and he was sent home on diltiazem 120 milligrams daily. What am I going to do? This patient did not pass out, minimally symptomatic. First thing I'm going to do, I'm going to stop the medicine.
yes,
Because he waited 35 years for his first episode. It may be another 35 years before he gets his second episode. Yes. Now, this patient goes home, comes back after 3 months with another episode of SVT. And at that point, I have to make a decision that now I need to treat this patient. And that is the point that we are going to make decision whether we send the patient for ablation or medication. Now, interestingly, that patient also had hypertension. So he needs the medicine anyway. So what I'm going to do, I'm going to put a calcium channel blocker and send him home. He comes back again after 3 months with another episode of SVT. Now it is time to consider ablation or increase the dose of the medicine. Here in America, 20 years ago, we insisted that they fail at least 1 or 2 medicines. Now we do not. We give patients choice. But remember, even in the best hand in the world, there will be heart block with AV node reentrant tachycardia ablation 1 in 200. And that we must remember that. So a clinical scenario, so not only ablation, the question is whether the patient needs medical treatment at all or not. Now, let's say that patient that I sent home without any medicine comes back after 5 years, another episode of SVT. What am I going to do? I'm going to send him home again, because go and wait for 5 years, it will come back again. Because if I treat him with medicine, I will have to wait for 5 years before I know the treatment work, whether it is ablation or medication. So these are the important points that we have to consider. One of the things that we do when you send these patients home, we make sure that the patient can reach me. So I tell them, call my office if you have a problem, and then we'll take care of you. Please remember one thing, that if I'm a patient, I'll be very anxious. And if a physician says, you can call my office and I'll get back to you, and if I really do that, it's a big, big comfort for the patient. And I think that is important, that we are giving support, psychological support to the patient, that he said, look, I'm not lost. I have patients who travel out of the country, and I tell them, if you get SVT in Germany, call me. I have friends in Germany. If they go to Bangladesh, I tell them same thing. You go to Bangladesh, you have a problem, call me, and then I will find you a doctor there, because it will be easier for me to find a doctor. So whole point is the compassion and proper caring. Thank you. Are you going to do the question answers?
There are a lot of questions, but I think we should move to the next session,
Right.
the interactive ECG session by Dr. Rafiq Ahmed sir. Sir, you can start. By the time you are sharing your screen, a quick comment on a question: how to differentiate sinoatrial reentry tachycardia and sinus tachycardia? Ata sir.
I think Firoz.
Okay, we
Sir,
can go for the next session. Okay.
During the ECG, we can discuss the issue, but already Sir has shared the screen. I think we should concentrate.
Okay, sir. Okay, sir.
Okay. So my point focus is to look at ECGs that are relevant to the lectures. But please remember, patients don't come to us with announcements. So I may change topics. My ECGs today will also touch into the situation where we have computer-generated ECGs. Sometimes they are correct, sometimes they are not. And it will. So first question and the answer and discussion will be Professor Odud for this lecture. So this is the patient. And I think we have the computer system today. Choice of 1, 2, 3, 4.
Yes, sir. ABCD, sir. Oh, 1, 2, 3, 4.
It's fine. You can call ABCD.
Yes.
One will be A.
Tarek.
কামরুল ভাই
স্যার
পোলটা চালু করেন পোল
ওকে
So instead of 1, 2, 3, 4, please use ABCD. And Firoz will keep time.
Yes, sir. Okay, sir. Okay, sir. Sure, sir. I think we have crossed 30 seconds time.
Sir, it started.
তাহলে স্টার্ট ইজ সেট
Oh, now we start now? Okay.
স্যার আপনি বললে স্যার আমি স্টপ করে দেব স্যার
Okay, dear attendants, please go for the comments again by A, B, C, D. Those who have already made comment, make the choice again.
30 সেকেন্ড ওভার স্যার ঠিক আছে স্যার আপনি স্টপ বললে আমি স্টপ করে দেব
Can we see the answer?
You can stop now. You can stop now and give us the result. Most of the result, 47% is C, 19% A, 9% B, and 26% D.
Well, my plan was
47.
Okay. My plan was that I will say, Wadud, you are 100% successful, and it will be 100% somewhere. So I'll leave this for discussion to Professor Wadud, because he talked about ST segment.
Look at the ECG. This is a 30-year-old male. 3 days of constant non-exertional chest pain. Is it MI? If it is MI, 3 days old, there should be prominent Q wave. It's not there. So the number 2 is out. Number 1 is normal ECG. Well, if it is normal ECG, the patient has a problem. Why the patient has a problem? We should look for something else. So logically, normal ECG should not be considered. Number 3 is pericarditis, and 4 is early repolarization. Young men presenting with a slight ST elevation could be, but look at the ST elevation distribution. It's present in multiple leads anywhere. And whatever the, if his pericarditis has a choice, look at the PR segment in lead 2. It's slightly depressed from the TP segment. Look at the PR segment in MDR. Is slightly elevated. Widespread ST changes, elevation not typical of MI, not limited to a simple arterial territory, associated with PR segment depression in inferior leads and elevation in AVR is going to be, in this scenario, pericarditis.
Good.
But
Thank you. I
Chaudhary,
think
sir,
this is a classic ECG for pericarditis because you have all the features: PR segment depression, diffuse chest elevation, and
Sinus tape.
PR elevation in AVR, and some sinus, like a little bit of
Sir,
high.
sir, is there ST depression in lead 3?
Yeah. But remember that only lead 3, single lead, do not represent any definitive diagnosis. You have to have the similar change at least in 2 contiguous leads. That criteria is not fulfilled. Not 3 AVF, not 2 3. So only 3. So
Okay,
we have
Sir, what are the points against early repolarization pattern?
the scenario at number 1, the diffuse distribution, number 2, the PR segment change that's present in here. That's the point. These 2 are the plausible causes.
Thank you.
And this pericarditis has more meaning point. So we are going for pericarditis.
Thank you.
all right. Thank you. Next one.
Yes, sir.
Okay. So this is a 79-year-old female. I have written the heart rate there. It's 120 something. Yes.
You can stop now. It's 30 seconds. Show us the result. Sir, 50% says it is C, and 17% A, 17% B, 17% D.
Yeah.
This is a unique result. So
No, I
A,
think
B,
this
D,
is,
all 17%.
yeah, it is fair. I think that's pretty fair answer. So question would be, I'll leave it to Athar to discuss this ECG. I did not put a clinical scenario. The heart rate was 121, right?
Yes.
Yes, sir.
sir,
Athar, sir, please.
sir, it is the regular narrow QRS tachycardia.
Yeah.
We can see the POA before each QRS complex, but
Yes.
the PR interval is nearly about 200 milliseconds. The PR is particularly biphasic in lead 2, and it is negative in V1, and the P1 is also negative in case of the lateral leads, particularly V4, V5, and V6.
Yeah.
So my differential diagnosis, what we have written is that there is atrial tachycardia, sinus tachycardia. First of all, I want to exclude the sinus tachycardia, is because the POA morphology in lead 2 does not look like the sinus morphology, particularly in case of the lead 2. This is not the sinus morphology. So from lead 2, looking the P morphology, I can exclude the sinus tachycardia. Then SVT with AV nodal re-entrant tachycardia, the POF location does not support this diagnosis, sir, as because the POF is just in between. That is the it is the just short RP tachycardia than the long RP tachycardia. This is definitely we should consider, but it is by the location of the POF, it is not AV nodal re-entry tachycardia. Again, yes, it can be one of the differential diagnosis for the atrioventricular re-entry tachycardia.
Yes.
First of all, finally, sir, AVRT and the atrial tachycardia are the most 2 important things we have to consider. But because of the location of the POF, biphasic POF in lead 2, the negative POF in V5, V6, I will consider the atrial tachycardia first over the atrioventricular re-entry tachycardia, sir.
Okay. I think all the diagnoses. Other, yeah, go ahead.
Rate is 120 only.
Yes. So the rate is 120. Sometimes we see some slow SVT, atrial tachycardia, but I think all these are possible diagnoses. I mean, best would be if I see this patient in telemetry floor and If the heart rate is constant at 121, then I will say this is not sinus tachycardia. That will be the clue. Clinical scenario of the patient. But other than that, any of those diagnoses I will take. If you look at the P wave, I'm thinking that maybe in lead V1, I'm pointing the arrow. This is the terminal negative component of the P wave in V1. So maybe it looks like that. In lead 3 or 2, if you look at lead 3, the T wave is inverted, or I can't tell which is whether it's negative or positive. Which is distorting what. But if I assume this is positive P waves, so I think the possibilities are, all are those possibilities. Sinus tachycardia with first degree AV block, atrial tachycardia with a first degree AV block, and avinodal reentrant tachycardia, atrioventricular reentrant tachycardia. All those are equal possibilities. And I think there is a reason for showing this. And if you look at this is the August 8th, and next same day, little later, look at this. So this patient has baseline first degree AV block.
Yes.
And if you look at lead V1, it's a biphasic, and that superimposed on the lead 2, the funny looking. So basically that was sinus tachycardia with first degree AV block. And the point we are trying to make here to all the audience that none of us was correct. And so that's what medicine is all about. We look at the clinical scenario of the patient, but I think telemetry monitoring would be the main clue to this patient, not the single point ECG. And I will never put this ECG in an exam to determine whether my student is competent or incompetent to read ECGs. This will be an ECG that will be for discussion, because if I give this ECG to 10 cardiologists, they will answer all those answers that you have given me today. Thank you. So next one. This is a 61-year-old male, and this is the ECG, and the computer-generated ECG reporting is there also.
কামরুল ভাই পোলটা অন করেন।
পোলটা ECG কে ঢেকে দেয়, এটা একটা মুশকিল।
দূরে সরানো।
আচ্ছা, পোলটাকে তুই
সরানো যায়,
পোলটা মাইনাস করা
কার্সার রেখে
স্ক্রিন থেকে সরানো যায় ইচ্ছা করলে।
ক্লিক করে ড্র্যাগ করা যায়।
30 seconds is over. You can stop now.
তখন আবার ইয়েটা দেখবে কি করে, পোল দিতে চাইলে কি উত্তর?
I think what we should do, we should give about 20 seconds to look at the ECG and then give the poll.
That's better.
Right, sir.
So the answer is B for 80% and A 20%.
C and D 0.
C and D 0.
Amazing. This is good. I think this is fantastic. I mean, if we look at this, the computer reported a sinus rhythm with short PR interval. First of all, it measured the PR interval totally wrong. There is a P wave in lead 2. And if I measure the PR interval, it's about 160 milliseconds. But the P wave here is negative. And my first reflex was, this is an ectopic atrial rhythm. But if we look carefully, look at lead 3, there is a P wave and there is another one. So this basically is the atrial flutter. It's a slow atypical atrial flutter with 2-to-1 conduction. And if I took another diagnosis, I'd have taken probably ectopic atrial rhythm if I missed that ECG. Thank you. I think this is fantastic. So the same patient, I'll go to the ECG next. You see, when it goes to sinus rhythm, the P wave morphology totally changes. And I think that's why it's important always to find the old ECG to compare the rhythm. Next one.
Sir, one question.
Yes.
Regarding the previous ECG, when such a rhythm disturbance, should we look at the long QT that gives confusion? What could audience was asking?
In the long QT here?
In the previous this ECG, yes.
Yes. So if you look at the QT interval, it's about 460 milliseconds. Computer actually measured it pretty good. and then you correct it, it comes up long. The
Yeah.
problem with the correction is that when the heart rate is, it is so much variable, it's a little bit prolonged QT, and that of course will make it confusing, because the other problem is this QT long because there is a superimpose? I don't think so. The P wave is a little earlier than that. So yeah, there is a minimum. I'm going to report that as prolonged QT. A clinical significance, I don't know, and also it depends on which formula is being used.
Yes,
The multiple formulas come up with different kind of numbers. Okay, this one.
next ECG, sir.
Let's give them 20 seconds and then let's
Yes,
put
sir.
up the poll.
Yes, sir.
আমাকে বললেন স্যার কম অন করে দেবেন স্যার, কম অন করে দেবেন স্যার, প্লিজ স্যার।
একটু মধ্যে বেশিরভাগ পারবে।
The heart rate is around 100.
Now-
I'll give you
now
the heart
put the
rate.
poll.
Heart rate is
এখন pollটা
about,
দেন।
heart rate is about 114 beats per minute.
Taking, we can stop now. Show us the result.
Yeah. Oh,
So
fantastic.
75% it is D,
D.
2% A, 14% B, and 9% C.
Yeah. And so, I mean, I'll just talk in favor of who answered B. When I first saw this ECG, it crossed my mind, because if you look at the P and look at the T, it looks like there are is it flatter? But then, of course, the reason I put the inferior infarct diagnosis was there is a QS pattern. However, if you look in lead V4, V5, V6, you can clearly see the delta wave.
You can remove the poll box.
Yes, and then if you when the rate slows down, it becomes much better.
Yes.
See less pre-excitation, but you can clearly see now this is basically that was sinus tachycardia with WPW syndrome. Thank you.
It's a nice one, sir.
Yes, thank you. So this one, this is Athar's. Basically, Athar showed multiple ECGs like that.
And now put the poll box.
This should be 100% correct. What do you think, Athar?
Yes, sir. I think
A fresh memory.
do it, sir.
We can now stop. Stop it. Show us the result. So 54% says it is C, 40% D, and 4% B.
Athar, comment on this, please.
Sir, I think it is 100% as because the participants can see the P wave location. This is the regular narrow complex tachycardia. The heart rate is 150, just 148 like this. Heart rate is just less than 140, regular narrow complex tachycardia. So if we see the analysis, the morphology, that is location of the P wave. This is in the V1, this is the location of the P wave. That is just at the beginning, just after the QRS complex at the beginning of the ST segment. And I think that it is within just at the 80 millisecond from the previous QRS complex. Short RP, P is at the just 80 millisecond, giving rise to the that is RSR pattern pseudo-R in case of the V, and also the location of the P wave in case of the lead 2, lead 3, and the inferior lead. That is the just after the QRS complex. Sir, I am in favor of the AVNRT.
Number 3. C.
Number, yeah, I think if you look in lead V1, it's a very pointy retrograde P wave. It looks a little more than 80 milliseconds. But if you look at lead 2 or 3, this P wave is within 80 milliseconds of the QRS complex, number 1, and it is negative in 2,3 AVF. So the primary diagnosis, I will always tell AV node reentry. And I tell my patients or others that 90% of the time that will be correct. There can be some atypical accessory pathway. So if we find this ECG, negative P wave in 2,3 AVF within 80 milliseconds, I think AV node reentry is the primary diagnosis. Secondary diagnosis will be atrioventricular reentrant tachycardia. It cannot be sinus tachycardia. It is unlikely to be flutter because I can clearly see a P wave. I cannot see another P wave. So, thank you. So,
sir, can I comment, sir?
Yes.
Some of them are asking
lot
about the
of
ST
young
depression,
patient,
which
those
is a
who have
feature of
accessory
AVRT.
pathway very fast, then the P wave in the V1 looks in AVNRT like here, the pseudo R, but within the some accessory pathway, concealed accessory pathway looks like I found in the EP lab. I thought it is AVNRT, but in EP lab it is accessory pathway because the accessory pathway is very fast. So AVN or atrioventricular can take a maybe in this case.
Absolutely right.
Yes, sir. Yes, sir. I do agree with Dr. Mohsin. I had such type of problem. I thought it's a VNRT, but later I found it's left post-conceptual pathway, concealed pathway.
Okay, let me summarize what Dr. Mohsin and Dr. Jamil said. You see, AV node is in the center of the heart.
Yes.
And the PR in RP is very short. But if there is an accessory pathway just near the AV node, it will look exactly same. That's why when I look at this ECG, I always tell people I'm correct 90% of the time. I will never say 100% of the time. 90% of the time I'm correct, 10% I will be off. And that determination we make in the EP level. And that is the reason that when we study these patients, sometimes when we think AV node reentry, even in the lab, there can be confusion and we can fail to ablate them because actually we did not understand the mechanism, even in the lab. And in what I'm thinking is AV node reentry, but actually this is an accessory pathway, a concealed pathway, which is either on the left side, just near the septum, which can give rise to the similar picture. But for all academic purposes, 90% of the time, this is going to be AV node reentry. The next ECG is same. I'm going to skip it. We have other ECGs, so there is a P wave retrograde here. And the mechanism, we're not going to any questions. So the whole point is this is a re-entrance circuit in the AV node, going down the slow pathway, coming back to the fast pathway, and the QRS will be first QRS, and then there is a A wave. That's why you see the timing here will be within 80 milliseconds of the QRS complex. How about this one? Heart rate is around 200 beats per minute in this patient with narrow QRS.
You can show the pull box. Yes, the time is over. You can show the result. Sir, 41% it is D. For 34% it is C. 17% A, 8% B.
Yeah. Atahar or Mohsin, comment or Jamil?
So
close the poll box.
It's narrow complex tachycardia, and there are some definite P waves in the D5, D6, as well as in lead standard 1. This can be discerned, and so it's a long RP tachycardia. So I go in favor of atrial tachycardia, maybe an atypical AVRT.
In favor of the active ventricular reentry tachycardia, AVRT, because you can see the P wave after the 80 milliseconds. So most likely this is active ventricular reentry tachycardia with RBB aberration. Yeah.
Why not atrial flutter? Some people say atrial flutter. Why not atrial flutter?
That's a possibility.
It's a possibility.
Atrial flutter is 1:1, so it is, and then it can happen.
1:1 conduction.
Yeah. So
But sir,
this is the part. If it is atrial flutter, it will be 1:1 flutter. That means it's a little slow flutter. If it's 2:1, that's too fast a flutter. That's one. Now which is the P wave? In V6 there is a positive. Is it the P wave? Or in lead 1 there is a notching of this thing. Is it the P waves? If I take the notch as the P wave, then it's a long RP tachycardia. That makes the diagnosis of atrioventricular reentry more likely. And look at bottom rhythm, how it ended. If we look at this T wave, there is distortion here, and after that there is no distortion. And that helps me identify where the P wave is. Most probably this negative component was the P wave in here. And so by this ECG, clearly, I mean, first diagnosis will be atrioventricular reentry. Second, atrial tachycardia. Atrial flutter is very, very unlikely diagnosis in this case. So this is the patient. Patient had actually WPW syndrome, and that was induced in the EP lab and atrioventricular reentry tachycardia. But please remember, in all these are possible diagnoses. That's why I put those things in there. And again, how it happens that you go down through the AV node, produce a narrow QRS, and then come back up to the accessory pathway. How about this one? You can see heart rate is 140.
Kamrul bhai, please launch the poll.
Poll.
Yeah.
You can stop now. So 40% shows it's D, 30% C, and 21% B, 9% A.
Okay, this is Aadhaar ECG.
D.
Aadhaar.
Sir, V1 এর চেহারাটা একটু অন্যরকম না?
Yes. So V1, V2 is clue to this ECG. I mean, heart rate is 140. These are all of those are possibilities. In Aadhaar, please comment on that.
Sir,
actually,
yes.
you showed a similar ECG.
Stop the poll box. Yeah.
Yes, sir. This is a case of the long RP tachycardia, and all these things we should consider. That is the P wave. There is a regular narrow complex tachycardia. Heart rate is 140. That is nearly 150. And the P wave is positive just in front of the QRS complex in the V1. Also, the clear P wave we can see in V2, and all the leads we can see there, but except this one. So this is one of the example of the long RP tachycardia. That is RP is longer than the PR. So again, the differential diagnosis may be the AVNRT, atypical AVNRT particularly, or sometimes it may be the AVRT, or atrial flutter is definitely one of the possibilities when we look at the lead 2 and lead 3. But considering all these things, sir, I am in favor of the AVNRT, atypical AVNRT.
Okay, sure. So the point was, here is if you look at lead V2, you can see a P wave very clearly, normal PR interval. That makes the diagnosis of atrial tachycardia or some other reason. But what was bothering me was lead V1.
Yes.
QRS complex looks funny there. I mean, there are two terminal R wave. That is possible, but unlikely. So I kept thinking, is this a second P wave? And I can see the similar thing in lead V2. There is a notch after the QRS. And then if you put a caliper there, you will find that the timing is exactly same. And this is the first, I think, and then second, I will take a caliper. And then I will measure the interval to see if they measure. And they did measure. And then remember the date, 26 April at 11:36 a.m. Same day, another ECG, sorry. Same day, an hour later, the rate has slowed down and you can see the flutter very clear. So this was atrial flutter with 2-to-1 conduction. But of course, the other diagnoses are also possibilities. And that is the whole point, that look at carefully in the ECGs. Look at the V1 now. You don't see the second notch. I'm going to go back. You see the V1, there is a notch here. V2, there is a notch. And when I go to this one, V2 still looks funny, but in V1, that notch is gone. Almost, because it's V2, it is funny because there is some overlap somewhere, but not on a regular basis. So this is typical atrial flutter, and it's a sawtooth appearing flutter in lead 2-3 AVR. So this was typical flutter. So this is actually a study that I did when I was in England. No, later on. It's in Los Angeles. So this is we induced this tachycardia during electrophysiology study. And I have given the choices. What are the diagnoses?
কামরুল ভাই পোল লঞ্চ করেন।
Stop the poll.
Stop it, Kamrul bhai. Yeah.
So 62% says it's D, that is SVT with RBB.
Okay.
And 19% it is ventricular tachycardia, and 11% atrial flutter with RBB, and 8% atrial fibrillation with RBB.
Okay. I will take all those diagnoses except C. Why not C? Because this is very regular.
Regular, yes.
Please remember one thing. If something is very regular, one thing it is not atrial fibrillation. So that is totally out of question. The rest of them are possibilities. And of course, I agree with majority of the audience, SVT with right bundle. And look at lead V1, small r, big R. But then again, it's a little bit monophasic, not typical right bundle. I had the luxury of having 12-lead ECG on this patient. So that so having an old ECG helps. And this is the 12-lead ECG. Patient had baseline right bundle branch block, and I induced tachycardia. So it became right bundle branch block. So we'll discuss it a little bit. It brings it to the next ECG. And I have put the computer diagnosis. So we'll discuss both of them together because that will clarify the point. And Doctor sent me an ECG from in my messenger, and this is his ECG is exactly same as this ECG, and that's why I thought that we'll discuss it. Heart rate is 135.
So the poll box. You can stop now. So So 39% says it is SVT with RBB, 21% sinus tachycardia with RBB, 8% atrial fibrillation, and 32% ventricular tachycardia.
Again, if we discuss this, one diagnosis that I will not take is atrial fibrillation.
Atrial fibrillation, yes.
That is not a diagnosis because it's very regular. Everything else is a possibility. Now, this ECG looks deceptively narrow. If you look at lead V1, looks narrow. V2 may be narrow, but if you measure it carefully in other leads, like lead 2, it's actually 160 milliseconds. So the right bundle branch block pattern with QRS more than 140 helps tilt towards ventricular tachycardia. And then there are a few other criteria that we can use. Here it is. The RBB morphology in lead V1, monophasic R wave or QR pattern or RS pattern in lead V1 suggest VT. And if you look at lead V1 here, it is a QR pattern. And that suggests VT. In lead V6, you can have any of those morphologies, but RS ratio less than 1, which it does not fulfill. There is another criteria for VT that in any chest lead from the beginning of the QRS complex to the deepest point of S wave, if it is more than 100 milliseconds, that's VT. In this case, it is 110 milliseconds. So given all those criteria, this is VT. QR pattern in V1, more than 160 milliseconds, and this beginning of the R to deepest point of S, more than 110 milliseconds, it is VT. Well, I'm just claiming it to be VT. Is it really VT? So let's look at this. This patient, I'm not going to give you the background. This is July 13th, and the patient was put on amiodarone. Look at July 28th, patient presented with a similar tachycardia at a rate of 103. And now you can see something. Look at here. In lead V1 rhythm strip, there's a P wave. There is a P wave. Am I making it up? And then what I did, I pulled up intracardiac recordings. If you look in the bottom strip, this is the atrial signal, atrial channel, and this is the ventricular channel. This is the ECG. You can see P wave here. The big signals are P wave, and the small signals are far-field ventricular electrogram. That clearly proves the diagnosis. So if anybody had any doubt, I mean, this is how we reinforce our knowledge. We applied this AV dissociation formula, but one can say, well, Dr. Ahmed, you just made it up. And then, sure, it is possible that I'm just imagining it, but when I look at the intracardiac signal, I can clearly see this. So that brings us back that those criteria that were designed is correct. That means a QR pattern in V1 with right bundle, and then duration here more than 110 milliseconds from beginning of the R to the deepest S point, and that makes it VT. And that is the same ECG Dr. Doctor has sent me on the messenger. That one shows the QR pattern, and also this duration is more than 100 milliseconds. That is ventricular tachycardia. I think we're going to stop here. There are questions about management of white QRS in ICU. I think we should leave it for a different time session, right, Athar?
Yes, sir. Yes, session, sir. Please take it.
Now, okay, Athar, we should go to the next section.
Next session, yes, sir.
Everybody is so engrossed in the discussion. Actually, we have spent so much time, but we do not actually look at that. If I share a screen.
Can you see the ECG?
Not yet, sir. No,
আপনি
sir.
স্ক্রিন শেয়ার বন্ধ করে দিছেন, এটা আবার শেয়ার করেন।
সেম প্রবলেম।
স্ক্রিন শেয়ার
ভাই হবে আপনার ছেলের কাছে।
হ্যাঁ হ্যাঁ ECG
আপনি নিচের প্যানেলে এই জুমের নিচের প্যানেল দেখেন গ্রিন একটা ইয়ে আছে ব্ল্যাক আপ অ্যারো
জাস্ট
ক্লিক করেন
অথবা ছেলেকে ডাক দেন স্যার।
হ্যাঁ 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 আমি স্ক্রিন শেয়ার এখানে তো
নিচের দিকে স্যার শেয়ার
স্ক্রিন
প্যানেল
লোয়ার প্যানেলে ওই যে কোশ্চেন এন্ড আনসার চ্যাট তারপরে আছে হলো স্ক্রিন শেয়ার একদম নিচে ডান দিকে
হ্যাঁ দেখি আসলো
কি আসলো
আবু ওই যে আবার স্ক্রিন শেয়ারটা দেখো তো না স্ক্রিন এই যে ইয়াটা আমার এই স্লাইডটা দেখো এই যে
আসছে স্যার এখন আসছে স্যার
আসছে
বড় করতে হবে
টেকনিকটা শিখতে হবে so this was the ECG in the ECG of the week posted in the Facebook, and many of our participants has nicely answered to this question. And this is the ECG for Professor Abdul Chaudhary. This is the Chaudhary's ECG, and he is the best person and he is the most expert person to discuss this ECG. Professor Chaudhary is just.
This is a real life scenario. The patient came to me last week. The male person, diabetic hypertensive. He had an episode of chest pain a few weeks back. He was not mentioning that. He came with the complaint that he's having some shortness of breath while walking upstairs. He didn't have that before. And on questioning, he said that he had an episode of chest pain around 5 to 6 weeks back. Now, look at the ECG. The 12-lead ECG, initial ECG, they sent me over the WhatsApp. I see that sinus rhythm, limb leads unremarkable. In the chest lead, V1 quite all right, but a little bit taller. But V2, the transition is too early, and the T wave is too beautiful. Lead V2 should not show such a good quality T wave. And in accompaniment of a tall R, we should think of something else. So I asked my assistant over phone, they do the posterior leads. And look at that, V7, V8, V9. There is keyword. Actually, the patient had posterior MI. Now, answers, please.
Tall are in V1 and T upright in V1.
Tall are actually, most importantly, most visible in V2, lead V2.
Yes, sir. V2 is more prominent, pronounced.
Our
T upright, sir.
T is too beautiful. I always say that.
Yes, sir.
And whenever you have that, you have to have posterior lead to exclude or confirm the diagnosis of posterior MI. The most important thing is if you do not have the suspicion, index of suspicion in your mind, you are going to miss it. And unfortunately, if you give this 12-lead ECG to the echocardiographer, very often they also miss the posterior wall MI. They say some, maybe the LV dysfunction is there. And this is an old case. That's why you do not have an ST depression. The patient had history of chest pain quite a few weeks back. If it is earlier, the ST depression, if it is there, then it would have been a acute to posterior MI. It's not that. I think last week we had inferior MI, posterior MI, but this one is true posterior MI.
Sir, yes, sir. I think regarding our participant has nicely captured this diagnosis. Actually, sir, most of the participant has correctly diagnosed this case of the old posterior MI in the Facebook. So I think Professor Chaudhary is very much correct. He wants to teach how to diagnose the posterior MI, acute posterior MI, and the old posterior MI. This is the old posterior MI. In the last week, we have shown that the infralateral, that is the posterior extension of the inferior MI. And this week, this is the true posterior MI. This is the old true posterior MI. And this is the technique how to diagnose the true posterior MI. And I think the Professor Chaudhary's effort is actually and successful actually participant has nicely captured this concept, that is how to diagnose the posterior MI.
Sir, I think it's quite late.
Now, so
If
the
you-
We can finish.
poster for the next Saturday. Tarek,
পোস্টারটা দেখাবা?
জি স্যার। স্যার দেখতে পাচ্ছেন?
হ্যাঁ, হ্যাঁ, হ্যাঁ। আমাদের তুষার আসলে ও সবেমাত্র কোভিড থেকে সেরে উঠেছে, এখন তার তার বাসার তার মুরব্বীরা আবার অসুস্থ, তাদেরকে নিয়ে এখন হাসপাতালে ঘুরছে। তাদের সবার জন্য দোয়া করি আর কি আমরা।
জি স্যার।
এটা বড় করা যায় না?
আর একটু বড় করে বোঝা যেত স্যার।
হ্যাঁ, ঠিক আছে। এইটুকুই থাক, এইটুকুই থাক।
জি স্যার, জি স্যার।
Next Saturday, we'll have a ECG feast. The fiesta decoding arrhythmia myths. Our beloved Rafik sir will be there, along with Dr. Abhishek Deshmukh. They'll be talking about the brain arrhythmias and the tech arrhythmias. So we are eagerly awaiting for that, and everybody are invited in there along with your friends and acquaintances. Abbott Vascular is helping us along with our own favorite Beximco, who are always there.
Thank you, sir.
Thank you very much.
Thank you all.
আসসালামু আলাইকুম স্যার।
so Adil bhai conclude kore
Assalamu
den.
alaikum.
So we are going to conclude this session. Wadud sir?
No, this is we do not have any formal way of ending things. We are actually
saying good night and assalamu alaikum.
Assalamu alaikum and good night.
Good night, sir. Assalamu alaikum, sir.
Alaikum assalam.
Thank you, sir.
And thank you, Beximco. Thank you, all the panelists
Thank you, sir.
and teachers.
Thank you all.
And Firoz,
Thank you, sir.
wonderful moderator. We want to every